All right, we'll get started. Good afternoon. Welcome to Medical Grand Rounds. Today's speaker is Dr. Margaret Wierman. She graduated from Bryn Mawr College, did her medical school at Baylor, where she was also residency and chief medical resident. Did her research training and endocrinology fellowship at the MGH, and came to the University of Colorado in 1987. She's currently professor of medicine, physiology, biophysics, and OBGYN. And is that all? Just those three? Okay. She's currently the chief of endocrinology at the VA. As I was looking through her CV, I came across something I found interesting that I'll relate that I didn't know. She serves as a consultant to the National Hockey League and the Ladies Professional Golf Association for hormonal disorders. And she also is a consultant to the U.S. Anti-Doping Agency. You might have a lot of work to do with respect to that consultancy. Her research interests are the ontogeny of the gonadotropin-releasing hormone system and also the molecular pathogenesis of pituitary tumors. She runs the pituitary program at the University of Colorado, and she has VA merit review funding for that. I would be remiss if I didn't mention that this year the National Endocrine Society is giving her the Mentor Laureate Award for career commitment to mentoring and for making a significant positive input on mentees. On her CV, she lists 62 people that she has mentored over her career, which is really extraordinary. Most of them have university appointments at this point in time. Includes PhDs, fellows, and even medical students. So Maggie, thank you.
Back on. Okay. Sound okay? Yes. So when it came to be my turn to talk at Medical Grand Rounds, I decided to come back and revisit menopausal hormone therapy because it's been very apparent that we have raised a generation of medical residents, medical students that perhaps don't find this as part of their routine care of patients. So right now, raise your hand if in the last 6 months you've prescribed menopausal hormone therapy. So maybe 30% of the people. That was very different a few years ago. And so I thought it would be good to sort of go back and revisit to some of the more junior people in the audience that may not have gone through with what many of us have gone through from the 60s and 70s, where estrogen was thought to be the fountain of youth and you should put it in the water supply, to the 90s and 2000s, where you could get sued if you gave menopausal hormone therapy and you had a complication, to now where I think the pendulum is swinging a little more midline and with many less big swings and not. So we're going to use this. Everybody knows how to use these. The questions are going to be A, B, C, D. You hit them, so we're going to have 6 cases, and I'm not going to give you much time. So the first case is the first patient who comes to your office. She has newly diagnosed menopause. She's been amenorrheic for 6 months. She's symptomatic. She has hot flashes, dyspareunia, that means painful intercourse. She has sleep disturbance, and she's having some cognitive issues. She's active, normal blood pressure, normal lipids. She has a family history of coronary disease. And my first question is, in your practice, is she a candidate for menopausal hormone therapy? So start it. Hit your buttons. Okay, let's see. So 85% yes and 15% no. And again, I think that if in the 1970s and 80s, that would have been 90-10. And I think even 5 years ago, it would more have been switched, and it's coming back and forth. So let's put this in perspective. So menopause is defined as a cessation of ovarian hormone production. The average age in the United States is 51. We call it premature if it's less than 40, and there's a whole set of newly found genetic disorders that cause premature menopause, as well as autoimmune disorders and other toxic effects and surgery. Perimenopause, we used to say that it was short, 3 to 6 months. up to 18 months, and the new data from SWAN suggests that especially women who have earlier menopause can have symptoms and signs for an average of up to 8.5 years, and whereas women who have later menopause have symptoms and signs, if you look very carefully, hormonal and other changes, for about 4.5 years. So it's a little bit longer than we thought. So the topic today is where are we in 2016 concerning the risks and benefits of hormone therapy, and what are the alternatives, and are they any better? So when I was training, we were being taught that all women should be considered for hormonal therapy at the menopause based on some epidemiologic data that we'll briefly mention. But because there were randomized, prospective, double-blind, placebo-controlled studies that showed that physiologic doses of estrogen controls hot flashes. So we still know that. We know that they also control vaginal atrophy symptoms. The other issues, and we know now from the WHI and from other studies that physiologic doses of estrogen are some of the best treatments for osteoporosis. The big issues back before the WHI was designed in the late 90s were what were the cardiovascular benefits of hormone therapy, and were there some, with the idea that we knew that if we gave especially unopposed estrogen, but estrogens to postmenopausal women, the incidence of breast cancer would go up. And what was the yin-yang? And so as they designed the WHI, they really thought we should put it in the water supply. We can watch the breast, we can take care of that risk factor, and we will really help a huge group of women. And I think this is an important take-home as you think about any kind of intervention that you're going to give to a population instead of a patient. Anything we prescribe has risks as well as benefits. And that's where the biggest mistake was as we think about it. Okay, so why did we think that it was going to be so great? Well, there were lots of epidemiologic data that showed there was a decrease in coronary heart disease of about 35% in women who had taken estrogen, taken hormone therapy. It was retrospective, it was prospective, and it was case controlled. And there was a lot of biologic plausibility. There was a reduction in LDL with estrogen and Lp(a). There was a decrease in blood pressure, at least in the early menopausal time in women who take estrogens, decreased fibrinogen, improved vascular reactivity, and decreased adhesion factors, as well as its effect, estrogen, on nitric oxide and its effects as an antioxidant. After the WHI, everybody came back and looked at all that scientific data, preclinical and clinical, and said, oh, but maybe all that data was just related to a healthy user effect. Women who got prescribed hormone therapy in the 70s and 80s and 90s were healthier, they were better educated, they took better care of themselves, et cetera, et cetera. So let's talk for a minute about the WHI. And I apologize for people of my generation that have heard this to the nth degree compared to the younger generation that really don't understand how this was designed. And so it was a multi-center, double-blind, randomized, placebo-controlled. It was in the U.S., and it had two large arms. Women who got conjugated estrogen with medroxyprogesterone as the progesterone, and initially started with the cyclic progestin, but then it was unblinded because women kept having periods, so they went to continuous progestin with the idea that they knew better than Mother Nature and that we could stop periods, which women didn't want, by giving low-dose continuous progestin. Over 16,000 women were recruited that had a uterus, and then we'll talk about the estrogen-only arm. But look at the age. The age of recruitment was 63, more than 13 years post-menopause, and you could not be symptomatic to be recruited. Well, how did we give hormones before the late 1990s? We gave it to symptomatic women. And the average follow-up was 5.2 years. And, whoops. And as you can see, about a third, less than a third, were in the 50 to 59 range, but they weren't symptomatic. And then the rest were more than 10 years to 15 years post-menopause. And a few had used, but the majority of the women had never seen hormones. So that's important. So what was the initial take-home data? The study was stopped based on a very complex statistical analysis outcome measure that didn't just have one risk factor, i.e. increased risk of breast cancer, but did a combined analysis that included both cardiovascular risk and cancer risk, and stopped the study. And what was the risk? Well, the risk for breast cancer, and you're all familiar using relative risk with a confidence interval, was about a 26% increase in breast cancer. A relative risk of 1.23 is a little higher in the initial publication and then adjudicated. I don't know, it keeps when I use my thing. The stroke and the pulmonary embolism we're going to come back to. It was seen in all the analysis of the study. And there was documentation of a protective effect of continuous estrogen and progestin to decrease the risk of colon cancer by 40% and decrease the risk of hip fracture. So this was our first data that showed that estrogen decreased hip fracture. And it's a very potent anti-resorptive agent. Now, that data was so unexpected and it was so overwhelming that people spent the next 10 to 20 years trying to understand it. So there was a lot of issues related, and it really points out how hard it is to do prospective double-blind placebo clinical trials that are different than an animal model or a preclinical model. So first was the age of initiation of hormone therapy, and I think we've learned a lot since then. We don't start hormone therapy in 68-year-old women. We start it in women at the time of menopause. The second is the dose of estrogen they use. They use full dose Premarin, 0.625. Again, we would use lower doses. There's 0.45, 0.3 available. Again, in women who had been without estrogen. And when you remove estrogen, the ligand, you get downregulation of the receptors at different target tissues. So you may have off-target effects. The role of the increased BMI. 2/3 of these women had a BMI over 25, and 1/3 of the women had a BMI over 30. So these were obese women, and historically we had not given hormone therapy to obese women because of the potential risk of clotting issues. So again, it was a different population than had been the sort of practice of care. The next is the type of progestin. That probably isn't that important, but some data on some target organs suggest that medroxyprogesterone is more negative, perhaps in the breast, than natural progesterone or the cardiovascular system. Importantly, it was the impact of daily versus intermittent progestin. And I think those of you who do use continuous progestin, be careful, because I think the WHI at least tells me that intermittent progestin is safer than continuous progestin. There was a high unblinding rate, and that might have had either a pro or an anti-effect on the detection rate. And then if you put all this together, the absolute risk for an individual woman is an event of about less than 1 per 100 women treated for 5 years. But of course, the media went crazy with it, and the pendulum started swinging against estrogen. These data also supported and began the discussion of something that's very popular now, this issue of primary versus secondary prevention. This study was designed similar to the lipid trials. Remember, the first lipid trials were done for secondary prevention, and when they showed that cholesterol-lowering drugs work for secondary prevention, they went back to primary prevention. So the thought was that should be the way that hormones work. Well, unfortunately, hormones aren't lipid drugs, and that's probably not true. Now, in 2004, 2 years later, the other arm of the trial opened up, or was reported, and it got much less press. And these were women, almost 11,000 women, who were surgically menopausal. So that meant they didn't need the progestin, because if you don't give progestin, you get endometrial cancer, right? And so these were women recruited who only needed estrogen alone. They were a little bit younger, but they went to the same age range, and they were either given placebo or conjugated estrogen, Premarin 0.625. And that study went on to 6.8 years, a much longer study, because they didn't see the adverse effects that were seen in the other arm of the study. They did, in fact, have no increased cardiovascular risk. It crossed 1, but they had the stroke risk and they had the VTE risk. The breast cancer, they lost the breast cancer. We'd all been brought up from a basic science to a clinical point of view that estrogens cause breast cancer. So how could that have happened? Well, there's lots of data from people like Kate Horitz's lab and her junior faculty that have outlined that progestin is a growth factor in the breast. It's an anti-estrogen in the uterus, and it probably explains it. We lost the effect on colon cancer protection. What role does estrogen and progesterone have in the colonic mucosa? People are trying to figure that out, but we kept the hip fracture data. So here's a slide from that paper that again shows the consistent increase in stroke. If you give a large group of women estrogen with progestin or estrogen alone, there is a subgroup of them that are going to be hypercoagulable, and we need to figure out who those people are. So since that time, 2002 and 2004, the data has been reanalyzed and reanalyzed and reanalyzed and has all the pitfalls of reanalysis of data. But here's the most recent from Joanne Manson's review that sort of puts some of the data in perspective. So whether we look at the estrogen progestin arm or the estrogen alone arm, look at the cardiovascular risks. So suddenly, now in the reanalysis of why the study was stopped, it's not significant anymore. And the estrogen-only arm is a number below 1, but still crosses 1. Myocardial infarction is not significant. So we've lost one of the reasons we stopped the study with a big confidence interval. But we haven't lost the increased stroke, as you can see in the red box, in both arms, and pulmonary embolism and DVT. I must say, though, that in the study, when they started seeing this hypercoagulability in a subset of patients, they sent out a notice and said, take-home message, if your patient on hormone therapy is admitted to the hospital, stop the hormones. Or if they're going to have surgery, stop the hormones ahead of time. And that decreased the rate over time. So I think if you have one take-home clinical message, you have somebody's on hormone therapy and you're doing elective surgery, stop the hormones. The exact time is 2 to 6 weeks. Some people say longer. But think about that. Immobilization increases your clotting risk. So how can we understand this data? It was so unexpected to all these people who had spent their life saying put estrogen in the water supply, and now the epidemiologists had to go the opposite way and say don't give estrogens to anybody, we're going to kill people of breast cancer and cardiovascular disease. How do you figure it out? So some of the basic scientists went back to animal models, and the monkey is a very good model of the human for the vascular system. And this is a classic paper by the group at Wake Forest, in which they took monkeys and gave them a healthy diet, and then they induced menopause by oophorectomy, and then gave them an atherogenic diet with or without conjugated estrogen. And then they looked at all the coronary plaques in their vessels. And the animals that got estrogen had 70% less, suggesting that estrogen was protective to the vascular system. Another group of animals, they gave them the McDonald's and fast food diet their entire life. They overectomized them and continued the atherogenic diet, and the protective effect was partially lost. Estrogen is only one of many factors that influence atherogenesis, and we have to put that in perspective. Finally, they gave them the healthy diet, they overectomized them, they switched them to the atherogenic diet, and they waited. This is the timing hypothesis. They waited for the same period of time as more than 5 years in a human to not take hormones after the menopause. With a change in the vessel wall and the progression of atherosclerosis, they added the estrogen back and they had no cardioprotection. So this animal model and then other studies like it started people thinking about maybe the vessel wasn't the same in a premenopausal and a postmenopausal woman. In addition, and when they went back to the WHI data, they found that in a cohort of patients that they looked at of lipid profiles, that if you had a favorable lipid profile, it predicted an improved cardiovascular risk with either the hormone therapy or the estrogen therapy. And why would that be? Well, because in hyperlipidemia, you have this abnormal vessel wall and abnormal reactivity. And in a normal vessel, you have the acute non-genomic effects of estrogen to increase nitric oxide and improve the flexibility of the vessel wall. When there's already plaque there, there's data to suggest that estrogens destabilize the plaque by altering metalloproteinases, and therefore the plaque ruptures. And in those situations, those are the women that are going to potentially have more complications. They have followed it up with some coronary calcification scores to potentially look at function. And they looked at a subset of the women, and if they were on the hormone therapy, they had decrease in their coronary calcification score and progression over the period of the analysis. Again, it's very hard to keep going back to the WHI and dissecting that subset, since a lot of the women recruited to that study were not the kind of patients that we would consider treating with hormone therapy. And so because of that, people looked, again, to sort of, can we tease anything out? Again, you couldn't be symptomatic. You couldn't be having horrible hot flashes and get into this study. But they went back and did this secondary analysis that you probably have heard about, in which they looked at either overall age or time post-menopause. And you can see that the cardiovascular risks increase with age in both groups, either time since menopause or age. And time since menopause suggested, although, again, it's not statistically significant because you have this huge wide interval, that in the 50 to 59 range, that estrogens may have some evidence of a cardioprotective effect, which was lost and then reversed as women get older, and especially in women who had not been given estrogen at the time of menopause. That doesn't mean we have prospective double-blind placebo-controlled studies that says that estrogen prevents cardiovascular disease. So how do we explain some of this? I tried to point out to you, we need to have this interdigitation of the basic science and the translational science and the clinical research to take better care of our patients. And over this same period of time, we've now known that estrogen works in many different ways. It works as a classic estrogen, as a transcription factor, a ligand, to the estrogen receptor to turn genes on and off. It works now, we've found that it works and binds to a membrane receptor to activate intracellular signaling pathways, or to bind to non-classic receptors and modulate kinase signaling, which can then modulate many different processes in the cell, how estrogen is metabolized, what its half-life is, its target tissue, and its end organ effectors. And understanding more about that will tell us about how estrogens work at all these different target tissues. Now, investigators more recently went back and said, well, let's try to look at the time post-menopause when we normally would get it, and the NIH wouldn't pay for another study. They had spent so much money on the WHI, the two arms, they said, we can't do this. And so they got private funding to, it's called the Chronos study, from a nonprofit to do this study, in which they randomized women to conjugated estrogen versus transdermal estrogen. The idea, bypass the liver, less clotting effects, you may or may not get the lipid effects, with cyclic micronizable progesterone. The idea was that maybe medroxyprogesterone was really bad and natural progesterone would be better. And unfortunately, those papers are recently been published in the last 18 months, and they showed they had to have a much earlier endpoint because they're studying young women in the 45 to 50 to 60 range, and they looked at carotid artery intimal thickening as an outcome measure, and there was no benefit. There was no increase in coronary artery disease when women were given these types of estrogen, and there weren't really any other risks. In one part of the sub-study, they did a cognitive mood study showing no effect of these hormones on cognitive outcomes. And they did see an improved depression and anxiety score with the oral conjugated estrogen that was not seen with transdermal estrogen. And they wondered if it was related to the types of conjugated estrogen. So this was sort of disappointing to those of people who said, wow, it's a timing theory. It was tremendously underpowered, this study, with several thousand people and not 16,000 women. So I think this data supported the no dramatic increased risk in that population, but it didn't show a benefit. So when we're talking about cardiovascular disease now, heart disease in women, obviously the take-home point is we need to do more about the established risk factor reduction that we all know about primary prevention and then secondary prevention. And we need to not forget that in women, which often is done. So now let's go to the rest of our cases. Since the WHI came out, there's been lots of other studies about menopausal transition and different areas about how estrogen might help, hurt, or have no effect. So when the patient comes to you and sees you, if they're not having hot flashes, or if they are having hot flashes or symptomatic things, what can you tell them about the pros and cons of hormones? So here was a 49-year-old woman who came to us with worsening depression, and she wants to ask about the pros and cons of giving hormone therapy to her as she's turning into menopause for depression. She had menarche at age 12. That's normal. She's had 2 kids. She has a family history of diabetes and heart disease, no osteoporosis or Alzheimer's disease. Her BMI is 30. Her blood pressure is a little borderline. Her A1C is borderline. And she really doesn't have hot flashes, dyspareunia, cognitive issues. She really just wants to know, do hormones help mood at menopause? So what's your answer? Okay, start voting. Would you prescribe estrogen progestin hormone therapy for its overall health benefits and to help her mood? Would you prescribe it and an antidepressant for her mood? Would you prescribe the antidepressant but do not prescribe hormone therapy? Would you prescribe a lifestyle intervention with diet and exercise, or would you prescribe estrogen progestin hormone therapy and diet and exercise? This is the treatment of her depression. Okay. Oh, wow. Well, I mean, I think diet and lifestyle intervention is very good, but I think she's pretty depressed. And at least the point is that you're not going to prescribe the hormone therapy for depression. So what do we know about the benefits of hormone therapy? When we talk about individual patients versus we talk about populations, we ask different questions and we say different answers. Estrogen at physiologic doses and probably lower than the doses that were used in the WHI control hot flashes. And so we can go to the lowest dose that we can use to treat hot flashes. It improves quality of life. It improves vaginal atrophy. But what about mood? And what about cognition? So what about mood in the perimenopause? What do we know? The lifetime risk for women of a mood disorder is 10 to 23%, and there's 2 to 14 times increase at menopause. Wow. We sort of knew that from our mothers and grandmothers. The problem is the data are quite bad, right? Poor quality. So there was the idea of the biologic sensitivity of hormones, vasomotor symptoms, women don't sleep as well, they're, sleep disruption, that'll make them more moody. Psychosocial factors, past history of a mood disorder, their attitudes about mood or depression, life events, divorce, kids leaving, coping styles, social support, socioeconomic status, and education. And then lifestyle, women who smoke have earlier menopause, have worse menopausal symptoms, no exercise, and increased BMI, increased mood disorders. So here's some data from the SWAN, which Nanette Santoro of our institution has been a part of and is one of the authors on many of the papers from SWAN, in which they looked at risk of depression in various ethnic groups. And so you can see the status across they looked at the transition, early, mid, and postmenopausal. And you can see different races, so Hispanic have increased depression, and Japanese compared to white or other ethnic groups, that upsetting life events really predict it, and vasomotor symptoms predict it. But the data shows that hormones do not treat underlying mood disorders. What you can tell your patient is all the neurotransmitter neurons have steroid receptors on them. And so in the perimenopausal or menopausal transition, mood disorders can be made worse in an estrogen-deficient environment. So we never start hormones for an underlying depression, but sometimes starting hormones improves the depression or makes the mood stabilizers work a little bit better. Okay, get ready to vote. 48-year-old woman comes with stage 2 breast cancer. She's had surgery and chemotherapy and radiation a year ago, and she has intractable hot flashes. She has anhedonia, she's depressed, she has sleep disturbance, cognitive issues, much worse since she began an aromatase inhibitor. And everybody remembers that the aromatase inhibitor, unlike the SERM, which competes on the estrogen receptor and is a partial estrogen agonist-antagonist, when you're on the aromatase inhibitor, there is no ligand around. So none of your target tissues are getting any estrogen. And you're going to see a dramatic phenotype at all the target tissues of no estrogen action. So what do you advise? Should she increase her soy intake? Should we give her a serotonin reuptake inhibitor? Should we give her gabapentin? Should we give her low dose, she's only stage 2, estrogen and progestin therapy, or should we switch her to tamoxifen? Okay, we got a little of everything. Okay. So the data is so much better, at least in the oncologists in the group, if there are any, can comment on this. We're not usually switching people to tamoxifen because the data the aromatase inhibitors looks so much better to prevent the second breast cancer. We usually won't give hormone therapy to somebody with breast cancer, and the data for the serotonin reuptake inhibitors, although it's not the 90 or 80% effectiveness of estrogen, it is about a 40 to 60% effectiveness. Gabapentin is a second-line therapy, and soy, it's very variable. And the big problem with soy, it used to be that you had to eat 5 kilograms of tofu to get an estrogenic effect. But now that there's soy powders, women can get these powders that have so much estrogenic effects, you can actually make the breast cancer come back. So wouldn't be doing that. Okay, so hot flashes. Really big problem for about 30 to 40% of women at the time of menopause, much worse with surgical menopause or with aromatase inhibitor. We really don't understand the mechanisms yet, and we don't have effective therapies other than estrogen in comparison. It may be an alteration in the imbalance of how estrogen works on the serotonin reuptake inhibitor transporters, but we still don't know. What we do know is there's been several meta-analyses showing a minimal to no effect of soy isoflavones on hot flashes, and a variable effect, and this is a pretty old meta-analysis, but the data looks pretty good for the SSRIs or the SNRIs for hot flashes. So that would be our first drug to try in somebody who can't take hormone therapy. Okay, next case. She's a 52-year-old runner. She comes from Boulder. She's taking low-dose hormone therapy, and she's using the estrogen patch at 0.05 twice weekly, because the once-weekly ones often fall off. And she's taking Provera medroxyprogesterone 5 milligrams at night, works better at night, days 1 to 12 monthly for the last year, and it's relieved many of her symptoms of estrogen deficiency. She comes to you because she really wants to talk. She has a very strong family history of Alzheimer's, and she wonders if hormone therapy will help or hurt her risk. Okay, she has a strong family of Alzheimer's and wonders, will it help or hurt? This got a little simplified, but should, or no change, no effect. But, okay, let's see who votes. Help. Okay, so what do we know about estrogen action and neurocognitive dysfunction, especially Alzheimer's versus vascular dementia? Okay, so from estrogen and Alzheimer's, before the WHI trial was done, there were randomized controlled studies of low-dose and higher-dose estrogen, conjugated estrogen, in patients with established Alzheimer's that showed that estrogen had no effect. It's a very much the primary versus secondary issue. And established Alzheimer's disease. The study that's quoted the most is a Cache County cohort, though, that was a prospective study, observational study of 1,300 women and 1,300 men and 1,800 women who were in their 80s or in their 70s, and they looked at then the onset of Alzheimer's. And what they found was that the women in the cohort that had taken prior hormone therapy had an odds ratio of 0.59 of getting Alzheimer's. But it seemed to be only if they had started their hormones at menopause and continued for 10 years. So again, this theme of when you intervene on a target tissue, i.e. neuronal survival, neuronal functioning, that there might be an important role of doing it early when the steroid receptors are still around. Again, that kind of data. Now, that was sort of called into question when the WHI did a subset study called the WIMS, and then 2 different papers were published on that. But look at the design of the study. 4,000 women from the WHI. They're already 65. They haven't seen estrogen. And they looked at dementia and mild cognitive functioning. They had actually an increased risk of dementia if you took hormones. Oh, my God. So it was the opposite of all this epidemiologic data and some interventional study. But it turned out when it was adjudicated that it wasn't Alzheimer's. It's a different neurodegenerative process. It was the vascular dementia. So these were the same women who had the increased cardiovascular risk, the stroke risk. They're at risk for vascular dementia. There was no effect, however, of the hormone therapy on mild cognitive impairment, but their outcome measure was a modified mini mental exam, which is like, a hammer. Are outcome measures for cognitive. The more recent data suggests that estrogens have a role in verbal memory, and exactly when they work and how they work remains to be elucidated. But I show you this picture of what people are doing now. So researchers in a very small cohort use functional MRI to look at age versus hormone changes in verbal function. And what they could find is an alteration in phonemic verbal fluency and different regional brain activation in the frontal cortex that correlated as the FSH rose before the estradiol dropped. So that suggests that if we're more careful, we might understand how both testosterone and androgens and estrogens work in different regions, different targets such as the brain, such as neurons versus vascular systems, and understand their mechanism of action and understand when we should intervene or not intervene or alternatives to hormones when we can't use them. Okay, the next case, a 52-year-old runner had her last menstrual cycle 6 months ago. She has severe hot flashes and insomnia, but she's really worried, she's from Boulder too, about weight gain. And she just has heard that if you take estrogens, you gain weight. How many people have heard that? Yeah, birth control pills, anything. Okay, so what will you tell her? Her weight will go up on hormone therapy, her weight will go down on hormone therapy, or her weight won't change. Okay. Let's see. Will not change. Okay, let's look at the data. So it's really interesting. Everybody, well, we all get fatter as we get older, sorry, but the data shows this. So what do we know about estrogens and metabolism and body fat distribution? Women overall switch from a more pear shape to an apple shape with menopause. If you're an apple before menopause, you usually have polycystic ovarian disease. But estrogen and either alone or with progestin, actually it decreases the rate of weight gain at menopause. And that was shown in an earlier study before the WHI called PEPI, where they thought they could give estrogen to anybody, so they gave low or high dose conjugated estrogen without any progestin. Guess what? They got endometrial hyperplasia and endometrial cancer, but they showed that the weight changes were much less in the women who took estrogen. So 0.7 kilograms versus 2.1 kilograms at 3 years. So, but a question that Wendy Court's group here at the University of Colorado has been very interested in is, what are the effects of sex steroids on body fat distribution? And then, are there alternatives to hormone therapy, such as exercise? And this is an older study from the group, but I think it teaches us a lot. And here that we took women who actually are much older than what we would give hormones to now, at 68, and they gave them, you probably can't see very well, black is the control, then exercise alone, estrogen alone, or together. And what you can see on fat mass is exercise dropped your fat mass. Estrogen did not as well as exercise, but together they were additive, almost synergistic. So again, what are the mechanisms that do this? Is it estrogen deficiency and activation of cortisol that causes a more central weight gain? Is it an imbalance of estrogens and androgens? Stay tuned, but there are definitely mechanisms by which low-dose estrogens contribute to body weight distribution and weight gain in a positive way, not a negative way. Oops. So we've talked about the benefits of hormone therapy. Let's just concentrate a little bit on what are the risks. We know that women get more gallstones than men, and that's an estrogen-dependent contributor. The relative risk is about 1.5 to 2. The DVT, we've sort of emphasized along the way. There's a subset of women that are going to be at increased risk of stroke or DVT, arterial and venous thrombosis, if we're going to give that to somebody who's older, and we want to keep them, want to look for that. Maybe eventually there's going to be a little chip that you do when you go through menopause, and it sort of says, do you carry any of the genes, factor V Leiden, antithrombin 3, some other risk factors that would put you at risk for this. Endometrial cancer, if we give unopposed estrogen, we've proven it multiple times. If you give unopposed estrogen and you have a uterus, you're going to get endometrial cancer. But no, if you give 12 days of androxyprogesterone at 5 milligrams a day, and probably not if you give 2.5 of androxyprogesterone every day. But I've told you, at least my view, that daily progestin is not good to the breast. So I think the WHI says that there's an increased risk to the breast if you give continuous progestin. So what is the risk of breast cancer? Well, it's about 1 in 8 to 1 in 9, but it's not 9 out of 9. But the big problem is that women get breast cancer early, around the time of menopause. Somebody knows somebody who's dying of breast cancer, and then it increases with life. People don't get heart disease or heart attacks until their 70s or 80s. And then so the breast cancer concern is real, And it's an age-dependent process. And if you look at the meta-analysis, if you've taken prior estrogen therapy, there's not a lot of data that supports a dramatic increase in risk with physiologic doses short-term. Long-term use, and what is long-term? Is it 3 years? Is it 5 years? Is it 10 years? It probably is small. Family history might make you more concerned, although remember, only about 1 to 2 out of 10 breast cancers have a family risk profile with it. The relative risk is 1.25. It almost goes across 1, but the absolute risk is low. 1 case per 10,000 women per year. So you need to have that balanced conversation with the patient. And all the data supports that there is a decreased risk with decreased progestin exposure. Okay. Now, our last case, alternatives. 48-year-old woman with early symptomatic menopause and sexual dysfunction comes to talk to you, and she wants to know about potential therapies for both of these issues. What is her best option? Should you give her a testosterone patch at 300 micrograms per day? Should you give her DHEAS at 100 milligrams a day? Should you give her compounded bioidentical hormone therapy, testosterone, E1, E2, and YAM progesterone, which has been given a lot on the western slope? Or should you give her an estrogen patch of 0.05 with cyclic medroxyprogesterone, 5 milligrams days 1 to 12? Or should you give her raloxifene daily? Vote, vote, vote. Okay. Okay. So most people got it. So why are the other answers not good? We'll come and talk about it. The raloxifene daily causes worsening hot flashes. It doesn't improve sexual dysfunction, especially in the early menopausal year. Compounded hormone therapy we'll talk about, but there's a lot of risk and very little benefit of compounded. We have bioidentical hormones. An estrogen patch is bioidentical. Prometrium is bioidentical. So when your patient wants bioidentical, you say we can give you FDA-approved bioidentical hormones. But it's not the Sigma powder mixed up in a troche or some kind of cream that we don't know the pharmacology of that's done by a local pharmacy. So a word about testosterone. I chaired the guideline for the Endocrine Society on androgen deficiency, and there's no androgen deficiency in women. There's not a set of symptoms and signs, like in men, that you can attribute it to a low testosterone in women, and that's partly because the assay can't even measure what testosterone levels in women are. But there's not evidence of data that shows that if you bring those levels back to physiologic levels, those symptoms improve. Now, that isn't to say that there isn't a pharmacological intervention that might work. And so the data from the testosterone patch, which is not FDA approved, showed that high physiologic dosing, producing a testosterone in the 75 to 100 range, which we would see in PCOS, was effective in a subset of women with hypoactive sexual desire disorder. So this is a specific type of sexual dysfunction. And the effect size was quite small. There was 1 more satisfying sexual relations per month. But it was denied at the FDA because of concerns on breast and cardiovascular risk. In the phase 3 trials, there was both cardiovascular risk and breast cancer. So for HSDD, though, there are many studies, either estrogen alone with testosterone or testosterone alone, suggest that we could try it if we had a way to do it for 3 to 6 months, but discontinue if not effective, monitor for overuse or signs of hyperandrogenism. The problem is there's no testosterone available in the U.S. or in most countries. People talk about using off-label of the male testosterone gel, et cetera, but the levels are unclear. And the majority of women, that's a whole other topic, we can come back and talk about sexual dysfunction, but have other issues that can be targeted, and estrogen deficiency is one of them that can be targeted before you consider this. Long-term risk and benefit, we don't have any data, and part of the problem is the normative levels of testosterone in women across the lifespan are trying to be sort of elucidated with the new mass spec assays where we can measure levels down to 1 to 5 picograms. So, lastly, what about alternatives and supplements? So the SERMs. The SERMs were thought to be going to be great. Raloxifene, after the tamoxifen data came out, that raloxifene was brought out as a bone drug. It's called a mini estrogen. It's about half as effective on bone than estrogen is. And it decreased risk of breast cancer in the patients who took it. So it thought, well, wow, we use that instead. Well, in the early menopausal transition, raloxifene worsens hot flashes, so it's very hard to take. It also caused less endometrial cancer, but some endometrial abnormalities that tamoxifen had, and it did not have a cardioprotective effect in the large Ruth study. So the use of SERMs has really decreased. In the woman in the 55 to 60 range, who in the Gale model might have an increased risk, you could use it if she had pretty good bones and didn't have hot flashes for a period of 5 years, but its use has really decreased. Soy, meta-analysis, little effects. Herbals, that's a big thing. We see a lot of people using alternatives and supplements. You know, no beneficial in studies today. The big concern that I have in my patients is a drug-drug interaction. We see this both with men with hypogonadism and women, is the interaction of all the supplements they're taking or their protein powders, et cetera, and what's in those. Importantly, compounded preparations, there's just no quality control in them. Whether they're putting some cream or some gel, we don't have the pharmacology. Is there nothing in that, or is there super physiologic levels that then go to low levels? And that's why we don't recommend it. We have bioidentical FDA-approved hormone therapy that we can use. And then lastly, sometimes somebody isn't going to stop something, so I'll say, well, let's see before and after what it does to your lipids, because I know estrogen does something to lipids, or a bone biomarker in the appropriate to sort of take that into consideration. Or I have them stop and add back things one at a time to try to look at that. It's really scary to all of us as practitioners that the market for non-FDA approved nutraceuticals and supplements is like 5 times that of physiologic, ability to modulate hormone therapy with no outcome data about risk or benefit. So what's our take home? Short term, hormone therapy, the benefits outweigh the risk in symptomatic women. We don't give it, we don't put it in the water supply, but we treat symptomatic women. We use the lowest dose that controls their symptoms. We've switched predominantly outside of orals to transdermals to bypass the liver and to decrease the clotting, although there's not a lot of prospective data to show a huge difference in that. I think long term you have to weigh the benefits and the risks. Are there women in their late 60s or 70s that if they stop their patch they get horrific hot flashes or can feel the difference? That we talk about the risk benefit and continue, we do it. If the uterus is there, you've got to expose them to progestin, but as the estrogen dose goes down, you can do the progestin every other month or every 3rd month or every 4th month, as long as you shed the uterus and appropriately monitor for it. Importantly, lower doses work for different target tissues. Again, treat women at the menopause, not later, and alternative therapies do no harm. We need additional research. But as part of healthy aging, hormone therapy is just one little component, and obviously we have to all practice early lifestyle interventions. And with that, I'll stop and be glad to answer any questions. Thank you. There's mud.
Hi, thank you so much. Can you speak to what you think about using just the Mirena IUD with an estrogen patch in terms of, is that a nice lower risk potentially?
Okay, so the question is about using an IUD, a Mirena, this levonorgestrel IUD and estrogen versus progestin. So levonorgestrel is an androgenic progestin. So actually when I see a lot of women, it's being used now by OBGYNs in almost everybody. Before pregnancy, after pregnancy. It's really a bad choice for somebody with polycystic ovarian disease. Sometimes worsens hirsutism and acne and causes worsening lipids. So although, somebody with no cardiovascular risks, could have that as an alternative, it definitely keeps the endometrium down, and you could use low-dose estrogens plus that. There's no, as far as I know, there's some short-term studies, like a year, looking okay. But I'd be worried about the androgenic effects of the IUD on that. You could use a non-hormonal IUD and protect the uterus. But again, the progestin intermittently, as long as you're watching, and some people have said we'll use estrogen alone and just do an endometrial ultrasound, and when it gets thick, do a DNC. Has anybody had a DNC? I mean, it's not something you'd want to go through repeatedly. And so that's Probably not. But I think it's an individual decision of an alternative, but I would really watch the lipids and the androgens if you're going to use a levonorgestrel IUD.
Maggie, I realize that a minority of women newly menopausal have had a hysterectomy, but it's still a sizable group of women. And the long-term data suggests that they have, if they're treated with estrogen alone, they have reduced incidence of breast cancer and real strong suggestion that they have reduced coronary events when started in their 50s. That's a pretty remarkable package of benefits. And I wonder whether you might just say more about that. And
Sure.
Do you think there might be a time where, for a woman like that, we'd almost be obligated to discuss that potentially valuable form of therapy?
Yes, because I think, well, one, people who have early hysterectomies or hysterectomies at all are usually having them before age 50, right? And so that's sort of saying it's premature menopause. And so you could argue in that group, first of all, in that subset of the people who get the hysterectomies, all you're doing is replacing physiologic estrogen to the time of menopause. So I think the newer guidelines suggest in those women who have the hysterectomy before menopause, before age 51, that they are given physiologic doses for that issue. Now, the no breast cancer and no cardiovascular risk has a risk interval that crosses 1. So although the relative risk number is below 1, there's a lot of scatter suggesting it's fairly heterogeneous. I think that anybody who has an early hysterectomy should be given physiologic estrogens unless there's some other reason that they can't, some very early breast cancer. Now, whether they should continue it until they're 70, I think that's where we don't have as much data about it, doing it. But as you know, I give a lot of hormone therapy. And I give it to older women, too, because they're symptomatic. So I think anybody who's symptomatic. The other thing is that woman who gets surgical menopause has a more abrupt loss. She loses her androgens and her estrogens dramatically. And she's going to have usually more symptomatic menopause, especially if she's thin and exercises, et cetera, and the dose of estrogen. So whereas we used to use a 0.1 estrogen patch, and now the standard starting is a 0.05, you know, a woman who's 40 and has a hysterectomy may need 0.075 for a while to control symptoms. And we want to keep her more like a premenopausal woman, type that. So I think that early hysterectomy, you know, you remove the side effect of the progestin, and the estrogen effect is maybe more beneficial. I agree with you. Yeah. Yeah, so that's a great question. How do you discontinue hormone therapy? Well, I say to my patients, you're symptomatic now. We got to find the dose and the regimen that controls your symptoms. Then every 6 months, cut your patch in half and see if your hot flashes come back. And so for those who are having hot flashes. In women, you know, I think you're constantly asking what's the risk benefit. So I'm watching their blood pressure, I'm watching their lipids, I want their cardiovascular risk, their breast cancer risk, their weight, all those kind of lifestyle and aging issues and pros and cons. I would say, you know, for sure after age 55 to age 60, I am trying to go down on the dose. And I'm trying to get women down at 0.0375 or 0.025. But if they're symptomatic, I keep it on. When the person decides to stop it, often, you know, when everybody was getting hormone therapy, the data on refills showed, when we were just prescribing it, that only 25% of women refilled after 2 years. So it's the point of the same thing of sort of saying anti-prostate cancer using a 5-alpha reductase inhibitor or something. People don't refill when they're not symptomatic. Why is the compliance bad with blood pressure meds? So a symptomatic woman is going to continue the medicine and not. So the different ways, stopping abruptly often triggers bad side effects. So we usually cut the dose as much as we can, then we go every other day, or the patch, we extend it to a week, we cut the patch in half, it's not approved, you know, that kind of stuff. So I think the take home, if you're going to stop it, if you decide to stop it, abruptly will induce symptoms more than a gradual taper. Yeah.
Maggie, I want to thank you for prescribing hormone replacement therapy for me 30 years ago. My cognitive function is superb. My bone bone mass is that of a 25-year-old. And I'm now living in a retirement community where I wish that you had prescribed it for all the rest of the people. Taking the long-term view, it seems to me this is an N of 1. It has significant benefits.
As a scientist, yeah. Okay,
There's
thank you.
probably a lot of guys out there that want hormonal replacement now because of that. So thank you. Thanks, Maggie. Thank you.
You're welcome.